All right, so let's briefly go through some considerations for dysphagia therapy and some decisions that you have to make as the SLP. The first and most obvious is, can the patient safely take food by mouth or safely resume food by mouth? Or can they safely increase their diet level to be more normal? And largely, this is a decision of figuring out if the patient has appropriate airway protection to take food by mouth or for PO intake. If so, can they take in enough food to appropriately maintain their hydration and nutrition? So, for instance, you may have someone that has appropriate airway protection, but for whatever other reason, they can't take in enough food or liquid to maintain their body appropriately. You need to be asking yourself when you're signing someone up for dysphagia therapy, what is the goal of your therapy? What are you trying to do? Are you trying to rehab them back to normal? Or are you just trying to get them as on as good, as high a level a diet as is possible to maintain their quality of life, to increase their quality of life? Is it that you're trying to reduce the likelihood of aspiration pneumonia? And there will be plenty of patients that you see where restoration to normal is not possible. And sometimes restoration to anywhere even close to normal is not possible. Oftentimes you'll have these end-of-life patients like with ALS or Parkinson's, and they may already have a feeding tube. And you'll go in and need to evaluate them just because they want to be able to take something by mouth, recreational feedings, it's called. So maybe you're just going in as a pure quality of life thing to see, okay, this guy is going to be eating their Snickers or they are going to be eating their popcorn. I'm going to go in and at least discern what the safest way for them to do that is, to reduce as much as is possible, reduce the risk of aspiration pneumonia, and to heighten as much as is possible this person's quality of life. That's very different from I have a stroke patient or a TBI patient and I go in their hospital room the next day and I start working with therapy with an eye towards wanting that individual, shooting for them to be functional and as close to normal as possible. You want to know, what is the nature of the swallowing disorder? What is causing the problem? Is the problem getting the food to the mouth, as in a feeding disorder? Or is it one of the 4 stages of the mastication and deglutition that's affected? You may see patients displaying odd, abnormal, or even bizarre behaviors at times. And you want to ask yourself, why is this person demonstrating these behaviors? Is it because they're trying to compensate for some other issue? And the most salient example I can think of is someone that stops eating because they have odynophagia, meaning painful swallow, or someone that stops eating just because they know that they're going to get choked up on the swallow. But sometimes you have people who have adapted compensatory strategies for their dysphagia. And like we've said, they may be the appropriate compensatory strategies. You have people that have a delayed swallow reflex initiation. Sometimes they automatically pick up on the fact that they need to have their chin tucked to hold the food anteriorly and then raise their head up to move the bolus posteriorly to cue the swallow when they're ready. When you're looking at the patient, it's not enough to know what is the cause of the dysphagia, or if there is a dysphagia or is not. You need to know, is there a dysphagia? What is causing it? And then you need to know, what is the severity of this issue? And that is the realm of the instrumental assessment more than it is the bedside assessment, to discern the severity of the issue as well as exactly what the issue is. You need to be able to look at the patient and be asking yourself, is the diet level that the patient is on, is that appropriate for them? Is it too high a level for them? Is it too low a level for them? So an example of a diet level that would be too high might obviously one that a patient has difficulty taking, swallowing, and is causing some degree of aspiration or penetration, or is taking them an inordinately long time to get through the meal. Like, that patient may be able to eat steak and not aspirate or penetrate, but if it takes him 3 hours to do it, then that's not really functional. He's not really able to eat steak, at least in the nursing home. Maybe if he's at home, he's going to have that time and the people to work with him on that. They're flexible in the nursing homes, but they're generally not 3 hours flexible. A diet that is a diet level that is too low for the patient is one where the patient easily handles it and in fact could handle a higher level of diet appropriately as well. And there is a federal mandate that requires you to have the patient at their least restrictive diet, meaning their most normal diet level that they can achieve. So anything lower than that would be too low. And I've already basically said this, but the medical problem that the patient is experiencing, what is going to be their outcome? Are they degenerating? If so, you come at therapy in a different way than if you have a great deal of hope that they can come back to normal. So if a patient has a degenerative motor disorder, we'll say ALS, you are not going to restore that muscular function. In which case, what you're doing is putting into place compensatory strategies to keep the patient as safe as possible for PO intake. That is very different from how you would go about, we'll say, a stroke patient, where they've lost that motor function, but you can restore that motor function and be actively raising their level of ability, raising their level of diet, as you are probably also compensating for their current deficits, but you're providing restorative strategy, rehab, to improve them. Does the patient have a caregiver that is able to do everything that they need? To give you an example, I've seen a handful of patients at least that if they were in a long-term care facility, they would have to be on a feeding tube. But because they had a very dedicated and caring, loving caregiver, that caregiver went to extraordinary lengths to puree everything, to present everything that went into that patient's mouth or their husband's or wife's mouth at home with the utmost care, taking as much time as is needed, doing things that would be impossible in a professional medical or clinical environment. So the presence, the level of the caregiver is a big consideration. More often than not, you see the opposite of that, where the patient could, with maximal effort of the caregiver, devoting their livelihood to feeding that patient and keeping them well. Patient could go without a G-tube, but for whatever personal or economic reasons, the caregiver just can't manage that, and that's understandable, and that's a good bit more normal than the last scenario, in which case the patient has a G-tube, a feeding tube. And in that scenario, the feeding from the caregiver is more recreational feedings. You need to ask yourself, what is the environment that this patient is taking their food in? Is it conducive to their swallowing? If you have a patient with Alzheimer's, with severe attention and memory deficits, having them in the middle of a cafeteria with all kinds of stimulation is overwhelming. I have seen so many people with Alzheimer's, tray gets in front of them and they're sitting there and they are talking back and forth and they're cracking jokes and they're looking all over the place. But what they are not doing is paying any attention to their food, any attention to eating it, and certainly not using any swallow strategies that you may be recommending for them. In which case, probably a more quiet environment, free from distractions, would be more appropriate. So consider that we have different strategies that we use. Some of those are passive, meaning that the patient really is required to take no direct participation in the strategy. So for instance, thickening their liquid, downgrading their solids from normal to mechanical soft or pureed. No matter how cognitively impaired that patient is, they're not really required. You're not making any demands on their cognition. Altering the environment, the characteristics of the environment would be passive. Your active strategies are going to involve the patient needing to do something. So, for instance, a chin tuck. Patient, they're likely to penetrate unless they tuck their chin and swallow with every swallow. Patient has to be actively involved in that. And to do that, they have to remember to use that chin tuck. And to remember, they have to have intact cognition, or cognition intact enough to not just automatically be feeding themselves. And that's probably a pretty high level of cognition. We can also divide our strategies up into patient-centered and environment-centered. And this is exactly what it sounds like. Changing the environment would be an environment-centered strategy. Reducing the distractions would be an environment-centered strategy. Changing the person that is feeding the patient would be an environment-centered strategy. The last nursing home I worked at, we had this guy. He was, if you guys remember what Korsakoff's dementia is, it's sort of like a Wernicke style thing, but it's not in the realm of language, it's in the realm of cognition. So he was very confused all the time about where he was, what was going on. Most of the time, he was largely unconcerned about this. So he was pretty easygoing. He would walk with you. He would go through whatever cognitive strategies or exercises, whatever you're wanting to do. But he would not take food from anyone but this one CNA. Now, this is a guy that can't remember. You walk up to him, you introduce yourself. He says, "Hey, nice to meet you." You guys have a conversation. He looks away. He looks back. "Oh, I didn't see you sitting there." And he introduced himself again. So this is a guy that consciously at least remembers nothing. But he would take food from no one in that nursing home. But there was this one girl that They would have to call her from home. She lived nearby. She had to drive from home, and she would walk in, and he would do whatever she said. So the person doing the feeding can be a big deal. And we also have behavioral options for strategies, and this is essentially changing some aspect of how the patient is eating, or what they're eating, or when they're eating, or how they're eating, that is going to facilitate safe swallow. The first of these that we're going to think about in the realm of modifications to the food is thickening the liquid that they drink. And this is one of the things that we're going to talk about a lot in this class. And as SLPs, we do it a lot. But as I said at the beginning of class, this can have a very negative impact on quality of life. And you have to pay attention to that. Also, if you thicken their liquids and if they refuse to drink it, that could lead to dehydration, and that could be a medical issue. It's another thing you have to think about. Some people drink thickened liquid all day long and don't mind at all. We often downgrade individuals' diets from a normal diet to, next one down is mechanical soft, and below that is the pureed. And there are different facilities might have some additional in-between levels. These are the three main touchstones. There's normal, there's the mechanical soft, which is almost normal but not quite, and then there is the very abnormal one, which is the pureed. And the presentation of the pureed of the food can also be a big deal. So here you see a pureed tray from one facility. And over here, believe it or not, that's a pureed tray from another facility. So which one would you rather eat? Some facilities have like molds. So if they pureed the fish, they have a little mold that they'll put the fish in and plop it on the plate and pull the mold off so that the pureed is in the shape of a fish. And obviously most people are going to be more likely to eat that than just a big blob of gray, unidentified material on their plate. We play with the volume of the bolus. So some patients require a smaller bolus to successfully swallow. And you might be able to teach the patient that. But if they're unable to learn that, like for instance, many Alzheimer's patients, then you could simply give them a smaller spoon. And that patient will be automatically eating, but they'll have that smaller spoon, which will reduce the size of their bolus. Some patients benefit not from the smaller bolus, but from the larger bolus because it provides more sensory input. They can feel where it is more in their vocal tract, in their digestive tract, as it moves through the oral cavity and the pharynx down into the esophagus. And we've already talked about this in this class a few times, but we also play with the temperature. So a colder bolus, a bolus that is further away from the natural body's temperature, you're going to be able to feel that more. And if you're able to feel it more, it's more likely to cue a cough reflex when you penetrate or aspirate. Now, that being said, as SLPs, we rarely warm up things to increase sensory awareness. Obviously, because you don't want to burn someone or teach someone with Alzheimer's, with dementia or cognitive deficits, that they need to be eating hot food, because you have no idea where that's going to end up, probably with them doing some form of damage to themselves. We sometimes modify the feeding schedule of the patient. Some patients will sleep until noon. and there is just nothing you can do to wake them up. And so for that particular patient, needing to restructure their meal times so that they are awake and alert when their food comes. Now this is very possible in acute care and rehab. That's what they're used to. It becomes more difficult in a nursing home where you have a cafeteria that really relies on the hundreds of people that they feed to be on a pretty strict feeding schedule. Also, you might have to time their meals with the administration of their meds so that they're able to get the most out of their medication or take their medications and not be sick, nauseated. Also, as I've mentioned, some facilities, some nursing homes will have special rooms for feeding patients that have less distractions. There's more caregivers, there's more nurses, CNAs, LPNs in that room watching, cueing the patients appropriately than there is just out in the cafeteria of the nursing home where there's probably no one but the recreational therapist that might be putting on some sort of show or game for the patients, residents of the nursing home.
Tell me about your stay here so far.
Well, it was worrisome when I got here.
How's that?
I had to, Bob, let's see, how's it working now? Come here in the dark.
Yeah,
And
with Bob and Dana.
Bob seemed to know where he was going and everything. I didn't have much of any idea
Yeah,
which way of part of town I was going to or nothing.
yeah.
Kind of, till we got here. It's just, I was lost, in other words. Didn't know what I was doing, didn't know where I was going. But, and then I got in there, had to find things. I haven't been in a motel for 100 years. I don't know how to act.
Well, it seems like a motel, doesn't it?
Well, I'm calling it a motel. I don't know what else you can call it.
It's a skilled nursing facility.
Oh, what?
Skilled nursing facility.
This is?
Yeah.
We got lemonade or cranberry juice?
This place. It's similar to a hospital where it's full of nurses.
Oh, yeah.
Virginia.
See the guy with the wheelchair?
Nothing to get Virginia.
I'm recording you. What you want to say to the...
So you saw a guy there that is, if you work in a nursing home, you're going to see a lot of guys that look like that. If you noticed how highly distractible he was, I mean, she's talking to him and he's like this. And as he's talking, it becomes clear that he really doesn't know what's going on, really isn't overly concerned. And there's that uncomfortable moment where she tells him that he's at a nursing home and you're expecting some negative reaction, but he's already gotten distracted by something going on over there. So this is an example of a guy that would not do well. You could imagine him sitting there with the food in front of him and he wouldn't touch it unless he was in a place that had minimal distractions and someone there to prompt him. And there are some nursing homes that are much nicer than others. There's a whole spectrum. And also, some nursing homes, that special feeding room that they have is done up super nice to look like a fancy restaurant.
From the minute I walked in, the welcome we got, we had no hesitation in booking a place for Mum.
Since coming here, I've noticed a difference in Jean. She's much better, she's smiling now, you know. Every day is a lovely day.
It's the best home I've seen, the best nursing home. I was in some with my mother and now I've been others with my wife. I couldn't believe it. It's so good. Getting sentimental. The place itself is outstanding, really, especially in the summer. They've got a marvellous garden and it's really nice.
We moved Mum in here about 3 years ago, and it's a beautiful room because it gets the sun all day. She can see the horses from the window and the rabbits as well on the lawn.
Now than she ever did before, because what's put in front of her, she eats, whereas she was forgetting to eat and this sort of thing before. That's wonderful.
There's 2 chefs, me and Jack, and we've got kitchen assistants and we've got hostesses as well. As each resident comes in, I will sit with them and talk to them and their family if that's what they wish. We'll go through all the dietary requirements. Obviously they're all individual, they've all got their own dietary requirements, and we make sure that we provide a well-balanced nutritional menu for them. I'm actually a nutrition advisor as well, qualified, and I go by their feedback of what they like and what they don't like. My grandma is actually in a nursing home, and I've been there. I'm very critical anyway because I always think our place is so good. But even the choice there isn't like it is here. No, you know, everybody has to have the same every morning, every dinner. They're not given the choice, whereas they should be given a choice. Throughout the day and the evening, there's food provided for them all the time, and drinks throughout, 24/7. If I've got it, they can have it.
So y'all could sign me up for that. I'd go there now. Another strategy that we use is called alternating sip and swallow. And so this is for patients that have too dry a mouth, or if they have oral or pharyngeal residue they need to wash down, or maybe at times if they have a weak pharyngeal squeeze, and that addition of the wetness is going to facilitate that movement of the bolus through the pharynx. We also may use certain feeding aids. One example is called the nosy cup, and you can see the nosy cups here. They have the part of the cup rim cut out. And what this allows for the patient to tip the cup up without tilting their head back. Because if they're tilting their head back, that may be facilitating the liquid to rush back into the pharynx. So tilting the cup like this to take a little bit into the mouth allows the patient to keep the chin tucked, to hold the bolus anteriorly, and then to pull their head up and swallow when they're prepared for it. There are certain cups, and different facilities use different ones, but they're flow control, meaning that when the patient, and it looks basically like a big sippy cup that you would use for a child, patient turns it up and only like a certain amount of liquid is allowed to pass out through the cup into the patient's mouth. So the patient has to take small sips. So this keeps them from just pouring tons of liquid back into their oral cavity, potentially choking them up. I will acknowledge that most people who have these cups really despise them in my experience. And oftentimes these are dementia patients. So they can't figure out why, when they go to take a sip, they only get a little bit. But they keep drinking and they keep taking it, so they get enough liquid ultimately. Also, we've already mentioned glossectomy spoons. I mentioned smaller spoons a second ago for smaller bolus, bigger spoon for a bigger bolus, and weighted spoons. And this is more in the realm of OT, all the different spoons. But weighted spoons allow gravity to hold the hand more steady for feeding purposes. We change the position of the patient. The thing we do the most is do the chin tuck, and this does a few beneficial things to make the swallow more safely for most people. For some people, it makes their swallow worse, so you always have to customize what you're doing. But chin tuck is a big one. For some patients, turning the head, if they have a stroke and they have a weakness, a unilateral paralysis on one side of the pharynx, turning the head toward the weakened side pulls the strong side of the pharynx to midline. Now when they swallow, that bolus is passing entirely over the strong side of their pharynx, allowing them more control. We have strategies that we use to actually alter the mechanism, improve the functionality of the mechanism. So exercises, resistance exercises where the patient is pursing their lips against some resistance, pushing their tongue out, lateralizing it against resistance, puffing their cheeks out, keeping their lips closed against resistance. We might also do slow stretching, range of motion exercises, and this is more for reducing spasticity. And also we mentioned it in reducing fibrosis. We may go in and provide sensory stimulation to the oral cavity, maybe even to the back of the pharyngeal cavity, to increase the patient's sensory awareness of their mouth, to stimulate the muscles, to make them a little bit more tight, to increase the tone of the muscles a bit, maybe to better facilitate that swallow. And usually this is in the realm of cold, deep pressure, and there's probably going to be some sour taste on that as well. So often what this is called is deep pharyngeal neuromuscular stimulation, DPNS. There's also other names for it, but it's sensory stimulation. You take a lemon glycerin swab, and that's basically a big wet Q-tip with lemon taste on it. You put it in some ice, get it nice and cold, and then you go in and you stroke different parts of the oral cavity, different structures of the oral cavity, maybe the oropharynx, to increase the patient's awareness and readiness to use their swallow mechanism. And also prosthetics that can help the patient compensate for anatomical differences, such as palatal lift to elevate the soft palate to seal off the nasal cavity, or for instance an obturator if the patient has had a chunk of their hard palate taken out, as in the case of oral cancer, or maybe an obturator in the case of a child that has a cleft palate. So all these strategies that we're going to talk about more specifically in the future that are more patient-centered and active are exercises, compensatory strategies that you put into place. These are usually the exercises that you are trying to restore functioning with, require intensive practice, so many repetitions, many cycles of repetitions, multiple times a day. of many different exercises. And to get the compensatory strategies to generalize takes a lot of cueing, a lot of monitoring.